I know most of the people in this room are very familiar in the treatment of the different kinds of deformities. This talk will be only a summary of the different techniques and correction methods and perhaps the preoperative planning. So before I start this presentation, I want to define what's the deformity. I can define shortly pathologic variances if in the normal anatomy we can define as deformity. One of them, or part of them, or all of them is included in the definition of a deformity. The deformity can be differently in the etiology. It can be static, dynamic. Look at this is a static deformity, a post-traumatic deformity, or it can be dynamic, which can be corrected spontaneously, like a posteromedial angulation of the tibia, or it can be progressive, like an anterolateral curved CPT-like deformity in the tibia. So, as you very well know, there are two concepts or two definitions in the deformity planning: the malalignment and the malorientation. In the lower limb is very important, clinical important. The malalignment means the axial deviation, either laterally or medially, from the mechanical axis. And the malorientation define the position of the joints to the ground. You see a malorientated ankle joint here with a very well aligned lower limb. Before we starting to treatment, we have to assess clinically and radiologically the deformity or the deformities. The systemic assessment and the physical examination is essential. Establishing the limb length discrepancy if needed, and the range of motion, contracture, muscle powers. If there is any neurological problems, you have to note everything in the planning. And the correct radiologic evaluation is also essential for the treatment and for the preoperative planning. A long extending X-rays is always necessary, not in coronal plane, in both planes is very important, especially if you want to correct acutely in the operation. The blood test is always to recommend, especially in neurologic patients, because the limb length discrepancy that you saw or measure in the X-ray is not always the same with the blood test you did, especially in polio cases. The mechanical axis deviation, and this is the standard values that you well known by published by Dr. Paley, and also has been defined by Dr. Paley. The osteotomy rules to find the apex of the deformity, and if you plan to correct with an external fixator, you have to determine in which way you place your hinge as a open-up osteotomy, lengthening, or neutral wedge osteotomy, or very rare, but if needed to close the gap, you can use close-up a hinge. Either sometimes you have different points of the cora for correcting the translation as well, as you see here. So my story to learn this treatment of the deformity or handle with the deformities has been started in '93 in Kurgan. We did a visit with my mentor, Professor Chakmak, in '93. We saw a lot of different patients, very interesting patients. You know, Dr. Shetsov at that time was a director of the Kurgan Institute. And as you know very well, everything was not allowed to make a record. Only we see the pictures of the patients and to start to learn how to deal with this kind of deformities. My mind has been opened if I visit the course in Baltimore, especially this kind of this banana example has really informed me what's going on with the deformity. This is one example that I have the patient from with a valgus deformity come to me my office from Cyprus. If you see, it's a very well fixed femoral fracture with a curved plate. But if you see, it's a really huge genovalgum deformity. The problem was the rotational problem. They have fixed the distal fragment in huge internal rotation and created a huge genovalgum deformity, which I can easily treat it, removing the plate, only correction the rotation, everything was fixed. You see it in the clinical before the treatment. So after I learned the essentials of the treatment to correct the deformities, I have started every day making a paper tracing before starting the surgery. This was a 29-year-old female coming to me with bilateral coxavara and limping. She had also a distal femoral valgus deformity and 2 centimeters limb length discrepancy on the left side. So my plan was for the right side, just making a valgus and translation osteotomy and fixing it with a special produced plate. And on the left side, proximal osteotomy plus fixator-assisted nailing for correcting the distal part, valgus deformity. You see, this is the left one, starting in the first time in the left one. And this is the final result after I fixed both sides. This is another patient with vitamin D resistant rickets, has bilateral bowing deformities in femur and tibia. I did the paper tracing, planned to correct everything in one session. This is that I want to express that the paper tracing before the osteotomies or before the treatment is very important. This will be shorten your operation time. This is another patient has been operated in another center with 2 most probably valgization osteotomy years ago. This is, if you look close, you see the apex of the deformity is about trochanter major. So we have removed the plates and fixed with a unilateral fixator with translation here. And you see the correction of the femoral head, containment of the acetabulum. And at the same time, we corrected the valgus deformity in the tibia, both sides with plates. So I want to tell you, it's not dependent. You have not to be dependent to any device for correcting any deformity. You have to use which one is the most eligible to correct the deformity, then you can use this kind of device. Of course, there are the major steps, the Kodivilla and the Ilizarov in the deformity correction. Look at this case. This was a case coming to my office with a post-traumatic deformity in valgus and the recurvatum. I have treated this patient with proximal tibial osteotomy and with lengthening of the fibula for strengthening of lateral collateral ligament. And you see just after the removal of the fixator, it has been corrected and well aligned. Another patient with what I can use for correcting this Ilizarov, this is a neglected clubfoot. So I have decided to make a supramalleolar osteotomy and corrected it gradually with a Ilizarov type fixator. You see different steps of the Ilizarov. At that time, I have only a device for correcting the Ilizarov, not the smart frames, hexapods. And you see different, it was already 90 degrees, foot and the tibia. It has been corrected gradually and lengthening. And this is the final result with the external fixator. So Dr. Taylor comes to Arena with the hexapod and changed the rules of the games. Then we have started to use the hexapods. This is one of the my patients. The girl has is a burning structure, has an equinus deformity that we have corrected with a hexapod frame. You see, also she had a shortening in the femur. We lengthening the femur as well at the same time. You see the foot, the position of the foot, and this is the final position. Another patient, neglected clubfoot with a supination of the forefoot. We applied a hexapod or Taylor frame, and gradually we have corrected this deformity with the osteotomy, with the midfoot osteotomy. This is a very interesting case. Come to my office with 13 years of male with limb length discrepancy, deformity, and flexion contracture, and osteochondromas. I did a true cut biopsy. It was a benign chondral tissue. So we have decided to remove these osteochondromas, excuse me. And you see we did a intra-articular or subchondral osteotomy, an open-up osteotomy, and put a graft and fix it with two fixators. This is with the two screws, and this is a 8-plate for correcting the remains deformity. And then we put hexapod type external fixator and start to correct gradually the remaining deformity and lengthen it. And this is the result, corrected in both planes, sagittal and frontal planes. After that, I visit Baltimore and I stayed for a while there, and I learned a very pretty way for correcting the deformity called as fixator-assisted deformities, fixator-assisted intramedullary nailing. So I start to use this technique in my clinic. This is a lady coming to me with huge genu-valgum deformities. You see ulcers in front of the knee joint in the skins due to touching each other. And this is the preoperative, and this is the postoperative planning. This is one of my first cases with fixator-assisted nailing. Therefore, I was not able to do the left one with nailing technique. I did it with a regular external fixator, but another 3 segments I did with fixator-assisted intramedullary nailing. And this was before the orthoneurogenogram, and this was after the surgery. And this is the result, clinical result. Of course, in huge genu-valgum deformities, it's essential to release the peroneal nerve, not doing a drop foot at the end of the surgery. This is another patient with SWAP deformity. Mostly they are metabolic disease patients. I have corrected her in one stage with a fixator-assisted nailing technique, which is very comfortable for the patient, for the surgeon, and very short hospitalization time. This is another patient with huge deformities in frontal plane and in sagittal plane. The patient was very disabled to walk and for the daily life. She was sitting all the day in a call center and she was not able to walk too much. It was not able to make an orthoröntgenogram in one X-ray cassette because it was so huge deformity. So I planned her for each segment with a different X-rays. You see, always not to skip the sagittal plane. It's very important in the preoperative planning, a huge bowing deformity. And at that time, regularly I do it all in one stage, but due to huge deformities and due to planning, I decided to do two segments, one side in each session. This is just after the surgery in the right side. You see the limb length discrepancy in the left side. This is the pictures. And this is what I did after the both sides. And this is the clinical picture on the side view. Sometimes I use this correction with lengthening together. This is a cosmetical lengthening, you can tell. But the patients come in not for only lengthening of the stature, also he wants to correct the crooked bones. So he has also a medial axis deviation on both sides. So I use this fixator-assisted nailing plus lengthening over nail technique at the same time. You see acute correction of the deformity and starting to lengthening with a circular frame. And this is after the finishing of the operation, lengthening for 4 centimeters and corrected for both crooked bone. Sometimes I use this technique for correction of the congenital deformities, like this one has a sequela of fibular hemimelia, which is not able to walk. You see the great toe here. So I have did an osteotomy at the supramalleolar area and corrected acutely, put the nail inside. You see it's go through the tibia to the through the intercondylar notch in the femur. This is not a misapplication. This has been pre-planned for lengthening of the huge amount, and I fix it temporarily, the femur also with the external fixator. And then this is how it seems preoperatively. And this is how it seems after the operation. Also, I did a IP arthrodesis in the grade 2, and he is able to press the ground in the plantigrade. And this is the amount that I have lengthened. Then the internal lengthening devices was on the arena. You know, starting with Bliskanov nail, and there are a lot of nails on the market now, Fitbone and the Zimmer nail, and etc. Precise nail. There are some examples that I used with the correction of the deformities with motorized nail. This is a 14 years old female with epiphysetis sequela with shortening of 3 centimeters in the femur. I put a Fitbone. This is just immediately after the operation. And this is the postoperative 2nd week and 5th week. And this is the final result, lengthening of the 3 centimeters. This was a very easy case. So I have learned a lot from these pioneers and also shared my experience with them. So in my mind, deformity treatment is like a compass. Analysis and principles are like the pin and are determined. Our treatment techniques are like the pen, with many varieties, but always with the pen at the center. Thank you very much for your attention. By the way, I am very glad to be here with very distinguished people here. It was the 3rd time for me in Israel. I want to thank especially to Mark and to all of you inviting me here and sharing my experiences here with you.